If, like me, you've had too many anniversaries of your 40th birthday, you might realize that your vision for close tasks isn't as good as it used to be. This is a farsightedness condition called presbyopia. It's a natural result of the aging process. That means you may need to carry around a pair of reading glasses, which isn't terribly convenient, but it's a necessity for many of us. But did you know that there is a surgical eye care option that can quickly and painlessly free you from those reading glasses? To explore this topic of how modern laser surgery can restore youthful, close focusing vision, I'm talking with Dr. Erica Darian-Smith. Arian is a Sydney ophthalmologist and one of the principals behind Eagle Eye Surgeons, a clinic at the leading edge of innovation in eye care. She and her colleagues are, in fact, the only ophthalmologists who are currently performing Presbyond surgical technique to address presbyopia in Sydney. But first, who am I? My name is Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that helps independent eye care professionals to grow their practice. And I'm thrilled to begin this monthly discussion series about some of the exciting things that Eagle Eye surgeons are doing at their Mossman and Penrith clinics. So, hello, Erica. It's great to connect
Hi,
with you
Paul.
online.
Great to connect
So,
with you.
thank you. So, would you mind giving us the 60-second lightning round version of your backstory and how your practice came about?
Yeah, sure. So Eagle Eye Surgeons was started in 2024 by myself and one of my colleagues, who's the co-director, Dr. Mitchell Lee. He's a vitreoretinal surgeon. And it was started because we wanted to set up a practice that was cutting edge. So we have the latest technology. We wanted to be able to provide our patients with care, the best quality care because of obviously cutting edge technology, but also in the way that we want to form it. So it's a small boutique, independently owned practice, and we run it with our staff the way that we want to run it. And we're very comprehensive because we cover from the front to the back of the eye, and we cover all things from refractive laser surgery right at the front all the way to the back where Mitch is doing vitrectomies. So that's how it all came about. Mitch and I trained together at Prince of Wales Hospital in Sydney. So I've known him for a long time, and it was just something that we would always wanted to do. So we kind of joined forces, and here we are.
Fantastic. All right. Well, what is presbyopia? I've heard some people describe this as
Yeah.
long arm syndrome, where you have to hold the newspapers and phones and everything a little bit further away to read them. So, but what is it, and why does it happen to many of us?
Sure. So presbyopia is an aging process. So it happens to all of us, usually starting around the age of 40, and then it usually progressively gets worse into your 50s. And it essentially, I call it near vision loss. So essentially you lose the ability to see up close. And this is because your eye is no longer able to accommodate. So your lens is no longer able to change shape as it needs to see up close. And it's quite bothersome because it affects everyone, so no one's immune from it. And typically you'll start noticing it when things like menus or iPhones, so close-up items are no longer have that clarity. So you'll start getting kind of blurring of vision close up. And then, as I said, it usually gets worse the older you get until you completely lose accommodation, and then you develop complete presbyopia. So when you're in your 40s, we call it pre-presbyopia. So you're starting to lose that ability to accommodate. But then when you're, in your 50s or mid 50s, you've completely lost it. And then it becomes very apparent that you can no longer see menus and things. And you have to change your focal distance. So the long arm syndrome is because you're changing your focal distance to try
Mm.
and get it in focus based on how much accommodative amplitude you have left or how much accommodation you have left. So an 80-year-old won't have any accommodation and they won't be able to see up close.
So it affects everyone, does it? Like
It affects
regardless
everyone.
of what your default prescription
Yeah,
might
so
be.
it affects everyone, but if you're a myope, so if you're short-sighted, you're still able to see up close because of your prescription. So you'll still become presbyopic, you still lose that ability, but you'll be able to see. So you'll still notice that there'll be some change in your range of vision, but it's more apparent in people that are long-sighted. or people that don't have a refractive error. So there's lots of people walking around, we call them emmetropes, where they don't have any kind of refractive error. But then when they hit about 45, they suddenly realize they can no longer see their iPhone as clearly as before. So for people that are emmetropic or no script, or people like me, I'm long-sighted, we notice presbyopia a lot more, and it's a lot more bothersome for us. Whereas for myopes, it's not such a big deal, but they've always had the issue with the fact that they can't see in the distance clearly. So this procedure that we're going to talk about today, Presbyond, it's actually for people with all types of refractive error. So for myopes, so short-sightedness, long-sightedness, and no refractive error, it fixes refractive error, but it also fixes the near vision loss.
Okay. So, like, what have traditionally been some of the solutions for people who do get this condition of presbyopia? Like,
Yeah,
typically, what would people do if they were in that situation?
So the first thing people do is they make their iPhone font bigger to try and account for that. And then obviously we've got readers. So you can go to your local optometrist and you can get some reading glasses or magnifying lenses. So there's lots of those options. So that's traditionally what most people have done. And then there have been laser options for presbyopia in the past. So there's been different types of lasers in the past. Different companies have had different platforms of which that can be done. So there's also been laser surgery. And then there's also what we call lens exchange or refractive lens exchange. So that's where we, as surgeons, remove your natural lens in your eye that's no longer accommodating, and we replace it with a prosthetic or an artificial lens. And these lenses have the ability to correct for multiple distances. But obviously that's a more invasive procedure because we're going inside the eye. And usually we don't do that on anyone under the age of 50. Okay, generally. There's obviously exceptions to the rules all the time, but generally it's only for 50 and over. So it doesn't combat those early 40-year-olds or the 45-year-olds that are still developing this near vision failure.
Okay. So I think that Presbyond is maybe something that a lot of people haven't heard about yet. I think maybe I think LASIK is something that maybe more people are familiar with.
Sure. Yeah.
So would you mind like just giving us a contrast of what those two different procedures are?
Yeah. So basically, LASIK is a type of laser eye surgery. So we're operating on the front of the eye, which is the cornea. So it's the very front part of the eye. So you can see in my little eye model here, this is the cornea here. So laser surgery is all on the surface of the eye, and LASIK is a type of laser eye surgery. So there's multiple different types. There's LASIK, PRK, and SMILE. LASIK is the flap-based laser surgery. So I create a flap on the cornea, I lift the flap, I do the treatment, and I put the flap back down with my laser. And Presbyond is a type of LASIK procedure. So we're still doing traditional LASIK in terms of the surgical process is the same. However, the lasers that we use, so we have Zeiss lasers with the special Presbyond platform. So the lasers we use are very specific for this presbyopic profile that we put into patients' eyes. And with that, we have to take very specific measurements of patients. So it's individualized to each patient. So the beauty of Presbyond is it's a very mainstream procedure in the sense that we're just doing traditional LASIK, but we're using a very elegant and highly sophisticated program to essentially input certain numbers into the eyes to give you that range of vision that we'll talk about a bit later on.
Okay, so when you say a range of vision, is this what you mean when you talk about blended vision?
Yes. So as I mentioned before, with Presbyond or with this laser blended vision, we're not only correcting for pre-existing scripts or refractive errors, so pre-existing long-sightedness or short-sightedness, so we can correct for that, but we can also correct for the presbyopia or the near vision loss. And we do this by essentially making one of your eyes or your dominant eye is corrected for distance vision up to about the computer. So distance to intermediate. Your non-dominant eye is corrected from the computer to near. And that whole range of vision between your two eyes, which your brain processes, is the blended zone. So you'll basically have blended zone from distance through to intermediate, which is your computer, through to near, across your two eyes, which corrects your pre-existing script, but also gives you that near vision that obviously is becoming an issue for the 40 to 60-year-olds.
Right. So when we hear people talking about monovision, that's really just correcting for a specific like distance,
Correct. So
isn't it?
it's
Which is
actually
not what you're doing.
exactly.
Yeah.
It's a bit different from monovision. It's just a kind of more sophisticated version of monovision. So monovision is a little bit more rudimentary. It's very good, but it's basically your dominant eye corrects purely for distance, and your non-dominant eye corrects purely for a certain distance at near that we preset. So it's completely it's very rigid. You're just able to see your iPhone at this distance. If you move it here, it goes out of focus. If you move it here, it goes out of focus. It's set for a focal point. With Presbyond, it's blended vision because you have a continuous range of vision. It's a continuous range from distance through the computer, through to near, through to even if you bring it further up close, because it's taking into account a little bit of monovision. We use that as one of the many principles that we adopt as part of Presbyond. So we have a little bit of monovision, but we also couple that with some other sophisticated things like what's called spherical aberrations, which sounds very fancy, but basically we're just optimizing the eye to increase our natural depth of field. Okay, and we get that through our technology, so we can measure, for example, your spherical aberrations, and we can put that in our laser to get not only that monovision, but we also get that depth of field, which is why we have that blended or continuous range of vision.
Okay, so you mentioned about your assessment process, so maybe that's a good segue to my next question which is like who is the right candidate for Presbyond? Like I'm assuming that some people are maybe better candidates than others for this type of procedure.
Yeah. So look, with Presbyond, it's a pretty rigorous workup process. So when patients come to our clinic, they initially have a complimentary assessment with one of our optometrists. And then based on that, myself, so the surgeon will assess everything and we'll see if the initial assessment is suitable for them to go to the next stage. And suitability comes down to standard things for laser in general. So how like the anatomy of their eye. So is their cornea particularly thin? We look at, do they have a pre-existing cataract or lens change? Because obviously then they're not a good candidate for laser. We look at how dry the surface of the eye is. We look at their script. Is the script in a suitable range that the laser can give a really good outcome for? We look and see if they're going to be able to tolerate this laser blended vision, like if we think their brain is going to adapt adequately. And that's usually not an issue because 97% of patients do adapt. So that's usually not a major problem. But we do all of these things in our 1 to 1.5 hour assessment. So you can see it's pretty long. But we do all of these things to make sure that they're safe and they're going to get really good results from the Presbyond. So to answer your question, there are actually quite a lot of criteria that patients need to cross off. But when they do cross those off, we find that we're getting amazing results with our Presbyond. I think that's because, there's only a certain cohort of patients that are candidates for it.
Do you have any like special equipment that you use as part of your assessment?
Oh, of course. Yeah. So we have a pentacam, which is a corneal tomographer. So that looks at all the different parameters of the cornea, from thickness to how curved the front and how curved the back is, to looking at how much astigmatism there is. Then we're also very fortunate at Eagle Eyes to have an MS39 and coupled with an Osiris. So the MS39 is an OCT device that again looks at multiple parameters. So similar to the pentacam, it measures the corneal parameters, but also we can look at things like pupil size in the dark. So that's really important when you're doing laser, to make sure that pupils aren't too big so patients don't get side effects. And then we can also look at the cross section of the cornea. So instead of looking at the front and the back, we can look through the middle of it, and we can see if there's any pre-existing scars or any pre-existing damage. And then we can also look at the skin on the surface of the cornea and see if that's suitable for laser. So that's called epithelial OCT mapping. And then we have that in conjunction with the Osiris, which is essentially an aberrometer. So that looks at kind of visual distortions and things that you might naturally have that we can optimize. And that machine actually looks at the whole eye. So it looks at the front all the way through to the lens and to the back of the eye. And we're really lucky because the MS-39 and the Osiris are made in Italy. So they're pretty high-tech devices, and we find them pretty amazing. So we have those. And then we do a lot of other scans that assess the health of your eye. So one thing that I forgot to mention in my long-winded answer last time was that you need to have a very healthy eye to do laser. So you can't do laser or this treatment if you have pre-existing eye problems generally. I'm not talking about refractive error, but I'm talking about if you've had a previous retinal detachment or you have a macular hole or something like that, you may not be suitable, but it's still good to come in and have an assessment just to check your suitability, but they can be things that may exclude you from them.
Mm. What about certain like corneal irregularities, like keratoconus, for
Yeah.
example? Would that sort of would that kind of rule you out from
Yeah,
this
so for
procedure?
this procedure, for Presbyond, anyone who has keratoconus or even features that are suggestive of keratoconus, so they might not have a frank diagnosis of keratoconus, but they may have some things that are a bit concerning for a subclinical diagnosis. It's what we call form fruste keratoconus. So things like maybe their cornea is a little bit thin or they have some steepening of the cornea where we don't like it to be. So lots of those scans that I was talking about actually looks for early signs of keratoconus, and this is an absolute contraindication for laser, not just for Presbyond, but for laser in general.
And you mentioned I think you mentioned dry eyes because like
Yeah,
that's a common problem, especially as
yeah,
people get older.
yeah, yeah.
So I'm wondering like how does like does is are dry eyes really a limiting factor for you treating patients, or is Presbyond actually maybe, a better alternative to some of the other treatment options?
Look, I don't know if it's a better alternative. I think we have very sophisticated technology that can detect dry eye in our clinic. So the MS-39, you have a staring contest with the machine, and it actually looks at the tear film. It measures the tear film breakup and the quality of the tear film. And then we have another few devices that we look at for dry eye. And I think that whilst Presbyond necessarily isn't better than other treatments, I think that to have laser in general or LASIK in general, you need to have good overall quality of your tear film, and you can't have severe dry eye because we all know that laser can exacerbate dry eye in the short term. So what we do at Eagle Eyes is we make sure that patients have a safe level of dry eye to proceed with laser. That's the first thing. But also if we do detect dry eye, we are able to pre-treat it so we can get you to a suitable level for undergoing laser, but then also for your recovery. So you're not having a horrible recovery where you're putting in an eye drop every 5 minutes, right? So it's about optimizing the eyes to make them safe for the laser, but also it's about working out kind of what type of dry eye and how we can treat it. Because we have also a dry eye spa on site. We have treatments like IPL and things that we can optimize patients with before laser if we need to, or afterwards. And if someone has very severe dry eye, it's generally a contraindication for laser. But I have patients with dry eye that I've, for example, initiated Icurvis or a cyclosporin treatment for, and then they've been able to go on to have laser. So it's again something that it's very hard to make a generalization about. You really do need to just get assessed by myself and my team to see if you're suitable, and we'll only proceed if we think it's safe.
That's cyclosporin, that's an eye drop, isn't it?
Yeah, sorry, it's an eye drop. So it's like an anti-inflammatory eye drop for the
Yeah.
eyes.
Yeah. And IPL, that's
And that's another type of laser. So not the lasers that we're talking about today, which is obviously the lasers on the surface of the eye, like I spoke about. IPL is a laser, basically usually around the orbital or around the eye that we use to target dry eye. And we're basically targeting the blood vessels around the eye to reduce the inflammatory mediators that are released. So it's a different type of laser. It's a surface facial laser rather than the laser that we're talking about here mainly, which is obviously on the cornea.
right. So even if somebody, does have chronic dry eyes and they're thinking maybe, maybe I can't have this Presbyon, potentially there are things that you could do to help somebody's eye condition to bring
Definitely.
them to bring them up to a point where
Yeah.
they would be good candidates for it.
Potentially, yeah. So that we can generally optimize. As a general rule of like we can't make any general statements about whether they will or not be safe, but I do think it's still worthwhile, even if someone's been told they have a diagnosis of dry eye, they should still be seen, because there's a huge range of dry eye, basically. Like there's a huge range of most conditions. And yeah, you just need to have a proper assessment to see your suitability.
Okay, so let's say I've been on your website. I've looked at all the information about Presbyond.
Mhm.
I'm on board. I've booked a consultation through your website, and now I'm in your clinic. So can you sort of like talk me through what could I expect as a new patient there? Like what is the
Yeah.
procedure?
Yeah, of course. So, new patients to our clinic will get a welcome email from us, which will have everything included in it. So, in case you forget what I'm saying now, but essentially, the important things are that if you see an optometrist regularly, you should bring the referral in. Um, so, if you've got any previous refractions or previous scripts for glasses or contacts, we need to have evidence of those because one of the key things with laser is we need to have stability of script. And then the other thing is if you're a contact lens wearer, depending on the type of contact lens you wear, we want those out of your eyes at least 48 hours before for soft contacts and longer for hard contacts. So we'll give you an indication of that because contact lens wear can influence the results of the scans that we do. And it's really important that we try and have very accurate scans for the workup. So contacts, scripts, and any referrals. And then you should be aware that when you come to the clinic, you'll be dilated. So that process usually takes about 15 minutes for dilation. So that's where we put a drop in your eye and it causes the iris to become a bit bigger and it makes your vision a bit blurry. And the reason why we do that is not to put you through torture, but just to check the back of your eye to see if that's nice and healthy. So if you're a diabetic or just anyone, and we can also assess if you've got a cataract, because if you've got a cataract, we wouldn't recommend to go ahead with laser surgery. That might be a better option to do the lens-based surgery that I was talking about earlier. So the dilation is important. And the reason I mention that is the drops take a little bit of time to wear off. So usually about 1 to 2 hours. So you usually need to be able to stick around for about 1 to 2 hours after the procedure or have a chaperone that brings you and takes you home. But aside from that, that's pretty much all you need to do. And then we'll sort out the rest for you. So at the consult, we'll do all the scans. We'll assess if you looks like you're suitable in the preliminary phase. And then if you is, then the next step would be to see me or one of our other refractive surgeons. We have a few at Eagle Eye Surgeons. So, and then we would do a more thorough workup. And then we actually talk to you about the procedure in depth. And you have an opportunity to ask us whatever questions you want to ask as well.
Okay, so that's the initial point of contact, and then
Yeah.
so I guess the next stage would be to actually book in for
Mhm.
surgery, and like typically like how far ahead are you booked up for that type of thing? Can I get it
Yeah,
done pretty
so
quickly or?
usually there's about a month of waiting, but we can sometimes fit you in early if we need to or later if we need to, but there's usually about a month you can expect for laser-based procedures. For lens-based procedures, it's a lot longer because you're relying on external hospital time and space. So our lens-based waiting list is much longer than our laser-based because our laser-based is actually inside the clinic, which is great. So it's really easy for patients. They can just come in the same place where they were worked up. They've already met all the staff. Our laser suite's on site, so it's very familiar on the day of surgery. And it's also very quick. The procedure itself is only about less than 10 minutes per eye. So the actual surgical time is quick on the day. So as you can see, it's a very convenient and easy way to have this problem fixed. And it's a little bit less involved than if you need to go to a private hospital.
So I guess I'll call out the elephant in the room. Is it painful to get the procedure done?
I mean, we ask that question to our patients all the time, and the procedure is not painful at all. So the eye is numbed. So we put some freezing drops in the eye, and that basically numbs the eye. It doesn't mean that you can't feel tactile sensation. So you can still feel, what we call the speculum. So this is a little device that keeps the eyes open so patients can't blink during the surgery. So you can obviously still feel that going in, but you shouldn't experience any pain at all during the laser procedure. It's a painless procedure. And we have processes in place where if patients are feeling particularly anxious or, for whatever reason, we have processes and protocols in place and things that we can do for our patients to make them feel more at ease. The pain really, I don't know if pain's the right word. I think after the procedure, when you go home that night, you may feel a tiny bit of discomfort, like people describe it as a foreign body sensation. So kind of like if a bit of sand was in your eye, if you're over at the beach and you got a bit of sand in your eye. And that usually lasts for a few hours. Then you usually go to sleep that night. And by the next morning, patients come into our clinic and it doesn't look like they've had surgery. So their eyes are white, the foreign body sensation is pretty much gone. And no one ever complains to me of pain after Presbyond. Like maybe some slight discomfort that night at worst. But it's not meant to be a painful procedure because the eyes are numbed. And we're talking about like the incisions we make and the surgery that we do, it's all pretty delicate and refined. So it's not, yeah, that's not really a real issue that we have.
And how long does the actual procedure take, like the surgical part of it?
So, like as I mentioned before, it's less than 10 minutes per
Mm.
eye. That's not actually the surgery, like the actual surgery. That's more
Yeah.
just setting up. So we have to put the speculum in and clean the eye, numb the eye up. There's actually two lasers involved with this procedure. So the first laser, which is the Visumax 800, so that's the latest laser on the market from Zeiss, that creates the flap, and that flap is extraordinarily quick. You're talking like 6 seconds, 5 seconds. It's very quick to make that flap. And then we actually have to then move the patient. So the two lasers, there's a mobile bed in the middle of the two lasers, which actually just moves over, it swings over. And then we need to do the excimer laser, which is the laser that actually treats the refractive error, but also has this Presbyond profile to treat the near vision loss. That process is on the second laser. So after we've done the first laser, then the speculum has to go back in. I lift the flap surgically with some surgical instruments, and then I apply the laser to the eye, and then I put the flap back down. So actual surgical operating time is very, very minimal, but the whole process is probably about 10 minutes per eye by the time we're putting, speculums in and out and moving between two lasers. So patients do like the fact that it's quite quick, which means that, you don't have that long to kind of get too anxious about it. And then after the laser has finished, the patients then within our clinic will be moved back to my room, which they've already spent a lot of time in. And I usually assess them under the slit lamp just to check that everything looks good. So the slit lamp is actually here. This is like our little microscope that we look at the positioning of the flap, make sure I'm happy with that. And then the patient will just make their way down the corridor to our recovery area. And they'll usually stay there for about 10 to 30 minutes, depending on how they're feeling. And then they can go straight home after that. But on the surgery day, they do need to have someone bringing them to and from the surgery because we're operating on both eyes. And the vision will be a bit blurry the day of surgery, and that's just expected and normal.
Okay, so the next day, like any sort of discomfort's probably gone by now. How long would it take to actually notice like the results, the improvement in your vision? How long can we expect before that? I mean, you mentioned that the brain has to go through an adjustment process to
Yeah.
these new vision conditions. So how long would it take typically someone to actually start seeing the full benefits?
So by the next morning, when you come back to the clinic, we always see you at day one for an initial assessment. Your vision is basically very good the next day. So your distance vision is going to be 2020, very, very close to 2020. And your near vision will be very close to being able to see iPhone easily by the next day. So the actual aims that we go for, we see the results of very quickly. Next day, you're already seeing what you're getting.
Mm.
What I'm talking about with this kind of brain adapting usually happens over a period of 6 to 12 weeks. And we find during that time, whilst you can still see clearly for driving and you can still read your computer and your iPhone at work, there are periods where your brain might just suddenly go in and out of focus a little bit, your vision, either for distance or for near. And that is just your brain suddenly realizing, hang on a minute, something's happened, right? So that's what we call neuroadaptation, or what we call cross blur, which is when you get these symptoms of a bit of blur. And it's very variable what patients experience. We've done a lot of Presbyond now. We find that most patients, for the average, it's about 6 to 12 weeks. During that time, they're back at work. At our practice, we operate on a Friday, so we do a laser list every Friday. And most patients are back at work on Monday. So you can see the recovery is very quick. We do a lot of professionals and a lot of, electricians and people that need to go back to work. They've got their own businesses. They want to go back as soon as possible. So Friday, you're back at work on Monday, but the whole process where I would say your vision is optimized, or, you're getting that final product, is usually about the 3-month mark, where we find that patients come back because we see them 1 day, 1 week, 1 month, 3 months. It's usually the 3 months that they're like, oh, wow, my computer vision's really come into real focus now. So we find it usually is a little bit delayed in that sense. But there's a difference between like the vision that patients achieve and then the kind of blended vision or that optimization. And I would say that's what I'm talking about when I say it takes about 6 to 12 weeks. But they don't walk out the next morning. They're already seeing the targets clearly. It's just that the spherical aberrations, which I mentioned earlier, which is that depth of focus, that takes a little bit of time for your brain and for everything to kind of integrate.
Okay. So, yeah, it's interesting. You mentioned electricians as like one of the, patients, one of the types of patients that maybe this procedure can help. I guess a lot of tradespeople, they're doing lots of close work. So
Yeah.
a procedure like this could
Yeah,
be
we
very
get
helpful.
lots of tradespeople. We got lots of obviously office workers of all sorts. I mean, it's pretty much universal that everyone wants their distance computer and reading vision in this day and age.
Mm.
It doesn't matter what you're doing. You want to be able to see clearly when you're driving, and then you want to be able to look at the dashboard in the car. But then everyone has iPhones now. So I feel like everyone needs that range of vision. So we get kind of patients from all walks of life. Interestingly as well, which we haven't really touched on, is we've been talking about the patient that comes to the clinic who's never had any intervention before, like they're a new patient. But you can also do Presbyond. We do Presbyond on patients that have previously had LASIK. So, if you had
Okay.
LASIK when you were 25 and now you've got presbyopia, so we can do Presbyond on those patients. So we can basically kind of update your old LASIK or update your old refractive surgery. And then, so that's kind of one side. And then the other side is patients that may have had cataract surgery, and they may have had cataract surgery where the lenses were, the prosthetic lenses that were put in only corrected for distance. Then we can do Presbyond on the surface of their eye to give them more range of vision. So it's actually not just for those 40, 60-year-olds who have virgin corneas and, virgin eyes that haven't been touched. We can also, there's a cohort of patients that I do Presbyond on who have already had pre-existing laser eye surgery. And then there's also some of my 80-year-old patients that have had cataract surgery, but they want a little bit more range of vision because the surgery they had didn't give them quite the range that they wanted. So it does actually cover a bit of a broader kind of area of demographic than we originally discussed.
All right. Well, so you mentioned that the brain, like the patient's brain, has to go through an adjustment process, and I guess most patients find that's fine. But if there are like cases where people are struggling to adapt, like do you have any strategies or any follow-up
Yeah.
things that you can do in that case?
Yeah. So I think it's really important to reinforce that because the process for selection is so rigorous, and we actually do a lot of assessments for to check that if we think that they're going to adapt well before the surgery. So we actually turn down quite a few people if we don't think that they're going to adapt. 97% of patients will adapt though. So there's a high adaptation, and it's usually if they've passed what we call the cross blur test, which is one of the assessments we do in our clinic, they're going to adapt with time. It just may mean that instead of falling in that 6 to 12 week zone, they might fall into a 6 month or an 8 month zone. So I remember the gentleman that actually invented Presbyond, Professor Dan Reinstein, he lives in London. He had Presbyond and he actually took a year to adapt. So there is definitely, some I've had patients that have been fine after day one. So there is for a start, it's really important that there is a range for that. I'm just giving you the average. Secondly, there's no reason that you can't have a temporary pair of glasses prescribed. So that doesn't influence how quickly you will neuroadapt. Okay. So it's usually either going to be that you're having the issue at distance or you're having the issue up close. It's not going to be for both. So if you are finding that you're going to the cinema and the subtitles are going in and out of focus a little bit, you can just get some distance glasses prescribed temporarily. Okay. So that's usually what we would recommend. We keep a really close eye on you. We see you, as I mentioned, I've already touched on the follow-up, but we see you like a lot during the process. So you'll be seeing us regularly. Now, what's the worst case scenario? Say it hits a year and you don't neuroadapt, then you can just reverse the non-dominant eye. So it's really not like it's not ideal, obviously, but it's something that can be reversed. So you can basically retreat the eye that was your near eye and you can make it for distance, and that will still leave you with good distance vision and good computer vision. So what you'll be missing out on is that kind of close-up iPhone vision. So that would be absolute worst case scenario. We've never had to do that. I think that would be exceedingly rare, but it is good for people to know that there is an option, if it were to come to that.
Okay, well, this has been an absolute goldmine of information, Erica. So I think anyone watching this has learned a lot about this procedure. And like I said, you guys are the only ophthalmologists in Sydney that are doing this currently. So before we wrap up, is there anything else that you wanted to add?
No, I think we've covered it pretty well. I think, as I said, it's just good to see if you're suitable. There's lots of different options for presbyopia. I want to highlight that this is just one of many options like we spoke about. And usually I can find a good option for my patients. So even if Presbyond isn't suitable for them, then they usually go down the lens-based pathway with me and we find another way to get them glasses or contacts free, assuming they want to get out of their glasses and contacts. If not, then, that's also an option just to stay in them as well. But, it's been a pleasure, Paul. Thanks for chatting to me today. And, just our website has a lot of information on the procedure and also other procedures that I was mentioning. It's pretty thorough, maybe a little bit too thorough, but it's got a lot of information. So if anyone has any questions, they can always just touch base with our friendly team and we can chat to them about that as well.
Okay, so if anyone wants to get in touch to book a consultation, so they can do that through your website.
Yeah, so they can just go to www.eagleeyesurgeons.com.au and there's a booking link online, or they can literally just email our rooms or contact our rooms. All the details are on the website. There's also links through most of our social media. So through Instagram and Facebook, there's booking links as well. I think we have TikTok as well, but don't go to that. So there's lots of different ways that you can get in touch. And we're happy to answer questions. We get a lot of people inquiring, and that's totally fine. Our team's very friendly and very happy to take any questions as well.
And I think it's worth repeating that if anyone's in Western Sydney, you've got a new clinic or fairly new clinic that's opened up in the Penrith area.
Yeah. So we're doing assessments out here as well. And I'm actually at the Penrith Clinic today. So yeah, it's very exciting. So we've got the two locations, Mossman and Penrith, just across the road from the hospital in the Nepean Health Hub. So yeah, we're very happy to service people of Sydney. And yeah, as I said, if there's any questions, don't hesitate to reach out.
Great. All right. Well, if you're watching this and you found this content to be valuable, don't forget to hit the like button because it really helps us out in the YouTube algorithm. And also subscribe if you'd like to be notified when eagle eye surgeons release more valuable YouTube videos just like this one. Also, please follow the Eagle Eye Surgeons Facebook business page and Instagram accounts to see updates on the latest news, promotions, and events. All right. Well, thanks a lot, Erica. Thanks very much for your
Thanks,
time.
Paul. Thank you. See ya.
All right. Goodbye, everyone. Have a great day.